Welcome to Raaonline. This is Dr. Aditi. I'm a consultant in internal medicine at Mehta Hospitals, Chennai, and today we are going to discuss an extremely exciting topic. So today we are going to see how to approach a patient with hyponatremia. Hyponatremia is one of the most commonly encountered electrolyte imbalance that we see amongst patients who are admitted in the hospital. About 30% of patients with hyponatremia, they develop it during the course of stay in the hospital due to various variables that occur during the hospitalization. So let us discuss over the next few minutes how we go about in approaching a patient with hyponatremia. What are the steps that are required in the etiological evaluation of hyponatremia, and how do we treat a patient with hyponatremia? This will be the focus of today's talk. Now, sodium, as we all know, it is a very important extracellular ion. So this is a positive ion or a cation, and most of the sodium is in the extracellular fluid. So this is a very important extracellular ion, and we measure the sodium's concentration relative to the water in the body. The normal sodium is, the acceptable range is 135 to 145 milliequivalents. This is the normal concentration of sodium in the body. Now let us see how we approach hyponatremia. When the sodium level falls to below 135 milliequivalents per liter, that is when we refer to it as hyponatremia. Now, hyponatremia is extremely simple, but we often insist on making it complicated. This is because our approach is hardly streamlined, we are in a hurry to jump to diagnosis, and more than everything else, we are in a hurry to treat the patient directly without even getting to the root cause of the problem. So what happens then? We have the patient who goes back after treatment for hyponatremia, who keeps coming back with recurrent episodes of hyponatremia because the root cause has not been evaluated. So this is what we are going to see over the next few minutes. So what is the first and foremost step in diagnosis of hyponatremia? The first and foremost step is serum osmolality. Now, why is this so important in the diagnosis of hyponatremia? Because this helps us to answer a very important question. And what is that question? The question is there true hyponatremia or not? That is the question which is answered when we look at serum osmolality. Now, normal serum osmolality varies between 280 to 295 milliosmoles per kg of water. Now, when the serum osmolality is less than 280 milliosmoles, then we refer to it as true hyponatremia or hypotonic hyponatremia. When the osmolality is high or normal, we refer to it as non-hypotonic hyponatremia, or what was previously commonly known as pseudohyponatremia. Now, before we take the discussion any further, let us look a little bit into what serum osmolality means. Now, osmolality is a measure of the number of dissolved particles in a fluid. Now, the osmolality reflects the concentration of substances like sodium, potassium, chloride, glucose and urea in a sample of blood, urine or sometimes stool. This is used to evaluate the balance between water and the dissolved particles in the blood and urine. So essentially, osmolality is a measure of the solute to a concentration of the fluid. That is what it means. So generally, when we refer to it as osmolality, then this is usually measured as milliosmoles of the solute per kg of water or per kg of fluid. So when we look at osmolality of a particular substance in blood, we are looking at its concentration or at the measure of that particular solute per kg of the body water. This is what osmolality means. Now, when we look at something which is very similar, which is osmolarity, this looks at milliosmoles of the solute per liter of body water. Now, what is the difference between these two? Because milliosmolarity looks at the solute load per liter of water as opposed to per kg of water, which is what osmolality looks at. Osmolarity is often affected by changes in temperature. This is why we often look at osmolality, because this is more constant between the two. So, serum osmolality is essentially the solute load in a fluid concentration, which is represented as milliosmoles of the solute per kg of water. Now, from here we are able to see that generally, although 280 to 295 is the normal osmolality, somewhere between 275 to 295 is the optimal range. So, generally the patients do not develop any electrolyte imbalances or any clinical disturbances when their serum osmolality is in this range. Now, we all know serum osmolality uses three important variables when we calculate it. So, 2 into sodium plus blood urea nitrogen divided by 2.8 plus glucose divided by 18. This is how you calculate serum osmolality. Now, what is evident from this formula? You are able to see straight away here that sodium ion plays a very important role in calculation of serum osmolality. It contributes to almost 95% of the calculated serum osmolality. Both your BUN and your blood glucose are divided by large numbers, especially your glucose. So, actually, if you see in real time, they contribute to less than 5% of your serum osmolality. So, serum osmolality is directly proportional to your sodium, and it can roughly be calculated by doubling your serum sodium level. So, sodium is an extremely important ion which has a lot of effect on serum osmolality. So, what does this tell us? When sodium is low in a patient with true hyponatremia, your serum osmolality should fall too. If there is a disturbance in anything else and that is causing an artifactual lowering of sodium, in that case your serum osmolality may be normal or high, and hence it is referred to as pseudohyponatremia, which essentially means that primary disturbance does not have anything to do with the sodium level. That's what it means.